Cirrhosis of liver. Cirrhosis of liver has been asked many times, so it's the most important topic that you should read under hepatology. Followed by portal hypertension and hepatic encephalopathy, which are has been asked as 10 marker questions. And also hematemesis, acute variceal bleeding, has been asked as both 5 marker and 10 marker question. Under 5 marker, we have spontaneous bacterial peritonitis, acute variceal bleeding, and hypersplenism. Portal hypertension and hypersplenism we will cover under surgery. Viral hepatitis is also an important 5 marker and 10 marker. I urge you to go through viral hepatitis. Now, first we are starting with cirrhosis of liver. Before that, let's have a brief introduction about alcoholic liver disease. What is this alcoholic liver disease? The disease caused by chronic intake of excessive amount of alcohol, leading on to spectrum of diseases like fatty liver, alcoholic hepatitis, alcoholic cirrhosis, and hepatocellular carcinoma is called as alcoholic liver disease. The patient with fatty liver is the initial stage of alcoholic liver disease, where there is only perivenular steatohepatitis due to the accumulation of fatty acids inside the cells, hepatic cells. These patients are usually asymptomatic. They may occasionally present with right upper quadrant pain and jaundice. These are unusual symptoms. Usually they are asymptomatic. These patients have mild hepatomegaly, and on quitting alcohol consumption, the patient will revert back to normal liver, meaning the histological changes is reversible in case of fatty liver. If the duration of exposure to alcohol increases and the dose of alcohol increases, the patient continues to take alcohol for many years, then he develops alcoholic hepatitis. Alcoholic hepatitis is a condition characterized by the hepatocytes injury, and due to that, there will be break in cytokeratin intermediate filaments like CK8 and 18. Due to the oxidative stress inside the cell, there will be breaks in cytokeratin intermediate filaments. These breaks in the filaments, which are proteins, when they are broken into small misfolded proteins. So these misfolded proteins are normally cleared off in the body by ubiquitin proteasome pathway. In case of alcoholic liver disease, ubiquitin proteasome pathway is defective, leading on to accumulation of these misfolded proteins, causing Mallory Denk bodies inside the hepatocytes. And also, due to the oxidative stress, there will be cell membrane damage, and also there will be dysfunction of sodium potassium pump, leading to influx of water and electrolytes into the cell, causing ballooning of the cells. So ballooned hepatocytes are the characteristic feature of alcoholic hepatitis. The patients with alcoholic hepatitis may be asymptomatic, or they present with fever and rapidly progressive jaundice, proximal myopathy, and abdominal discomfort. So these patients, if they have severe hepatitis, in severe alcoholic hepatitis, due to the damage of hepatocytes, there will be the inflammatory cells in the body like neutrophils, B cells, T cells will try to clear off these damaged hepatocytes. So there will be inflammation inside the liver. So these patients presents with fever, rapid progressive jaundice, proximal myopathy, abdominal discomfort, and also they may have the associated symptoms like esophageal varices, proximal muscle wasting, portal hypertension, and spider nevi, without any cirrhosis of liver. Please note this point. And also, on doing examination, the patient will have hepatomegaly and splenomegaly. Splenomegaly because of back pressure secondary to portal hypertension. Now, the treatment of alcoholic hepatitis is we tell the patient to stop the alcohol consumption, which is the cause for all this disease. How we'll see shortly. And also nutrition. If the patient has severe alcoholic hepatitis and he can't consume the food, we'll give fine bore nutrition to fine bore nasogastric tube, or we can also give parenteral nutrition. The patients with severe alcoholic hepatitis has bad prognosis. And also those who have severe disease, we can give them steroids, prednisolone 40 mg per day, because there is inflammatory attack in case of alcoholic hepatitis. To reduce inflammation, we can give steroids, prednisolone 40 mg per day, and also we can give pentoxifylline to prevent fibrosis if the patient has severe alcoholic hepatitis. So if the patient has associated encephalopathy or ascites, we'll treat them accordingly. We also can give N-acetylcysteine because it neutralizes free radicals which are increased in case of alcoholic hepatitis. So gradually, with time, the patient will develop alcoholic cirrhosis, and also the cirrhosis may progress on to develop hepatocellular carcinoma. This about alcoholic liver cirrhosis. So we are seeing cirrhosis in depth because it's the most commonly asked question, and it's very important for an understanding of hepatology. Cirrhosis is very important topic. What is definition of cirrhosis? Cirrhosis is a condition where it's the end stage of all chronic liver diseases, where there is diffuse involvement of entire liver characterized by fibrosis, and there is impairment of normal architecture of liver leading on to the formation of regenerating fibrotic nodules. So the definition of cirrhosis is it's the end stage of all chronic liver diseases characterized by involvement of entire liver with fibrosis and impaired normal architecture of liver with regenerating nodules. What is the etiopathophysiology of cirrhosis? What are the etiological factors which are causing cirrhosis? There are, we can divide broadly into hepatic causes and biliary system causes. The hepatic causes we can further divide into hereditary causes and acquired causes. Hereditary causes like hemochromatosis, uh, Wilms disease, the cystic fibrosis, the glycogen storage disease. In these diseases, iron, copper, and glycogen storage diseases, the substance, the proteins will accumulate inside the hepatocytes, and these accumulated proteins or substances, the metals, proteins, and other elements will cause injury to the hepatocytes, thereby characterized by chronic injury followed by fibrosis leading on to cirrhosis in these set of patients. The patients with alcohol causes liver damage. How so? We'll see shortly. So alcohol is one of the most common cause of cirrhosis, followed by infections. Hepatitis B and C, chronic hepatitis B and C infections is been associated with cirrhosis. Also, co-infection with hepatitis B and hepatitis D also causes cirrhosis. Patients with NAFLD, that is non-alcoholic fatty liver disease, can go on to develop cirrhosis. Also, intake of certain drugs like methotrexate, sulfonamides, and other drugs will cause injury to hepatocytes. Chronic intake of these drugs can cause cirrhosis in these patients. Under biliary system involvement, we have primary biliary cholangitis and secondary biliary cholangitis. Primary biliary cholangitis is a condition where there is autoimmune attack to biliary system, intrahepatic biliary ducts, causing obstructive jaundice and secondary damage to the hepatocytes and cirrhosis. In secondary biliary cholangitis, obstruction due to gallstones, the carcinoma of pancreas, cholangiocarcinoma, all these conditions cause the obstruction of bile duct. This causes obstructive jaundice and secondary liver failure and cirrhosis. Venous diseases like Budd-Chiari syndrome, where hepatic veins are thrombosed, can lead on to cirrhosis. So these are the etiological factors which lead on to cirrhosis. You know what is the pathophysiology of this condition? Beautiful, it's beautiful. The damage to hepatocytes. Whenever the hepatocytes is damaged, it's followed by regeneration. The liver has great regenerative capacity. So the normal hepatocytes will try to regenerate. So the regenerating nodules will cause destruction and distortion of hepatic vasculature. This destruction and distortion of hepatic vasculature will cause portal hypertension in patients. Due to this, the patient can have secondary ascites. Also, since the patients have many regenerating nodules, many damaged hepatocytes, the normal functioning hepatocytes are reduced, leading to symptoms of hepatocellular insufficiency like jaundice due to increased bilirubin level, due to reduced conjugation and excretion of bilirubin, and reduced production of proteins like albumin, leading on to secondary effects. Also, reduced production of coagulation factors like 1972, increased ammonia due to reduced excretion of ammonia due to reduced metabolism of ammonia in the liver. So all these factors, the hepatocellular insufficiency causes all these factors and associated symptoms. Now, how does alcohol cause damage to the liver? Pathophysiology of alcoholic liver disease leading on to cirrhosis. This is the pathophysiology of cirrhosis, where there is hepatocyte damage followed by formation of regenerating nodules, which causes destruction and distortion of hepatic vasculature, causing portal hypertension. Also, due to reduced number of functional hepatocytes, we have features of hepatocellular insufficiency. So now, how does alcohol causes damage to the liver? Before that, the normal, the safe level of alcohol consumption, which is recommended in males, are less than 20 to 40 grams per day. In females, are less than 16 to 30 grams per day. If we see it for whiskey, in males, the males can consume up to 6. The safe levels not consume. Basically, we should not consume. If someone consumes, the safe level is less than whiskey, less than 60 to 90 ml per day in males, and in females less than 30 to 60 ml per day of whiskey can be consumed. This is considered as safe level of alcohol. If the patients consume the alcohol more than these levels, it causes the following effects. Now, any xenobiotic or any substances like drugs or exogenous substances are metabolized by liver. So here alcohol also enters the liver for metabolism, where alcohol is converted to aldehydes and aldehydes are converted to acetic acid. The conversion of alcohol and aldehydes consumes NAD+. The NAD+ is normally required for beta oxidation and other reactions in the body. So when alcohol is converted to aldehyde, one H plus is removed, it's added to NAD+, leading on to increased level of NADH and decreased NAD+. The NAD+ is required for beta oxidation. So there is no beta oxidation, leading on to accumulation of fatty acids, causing steatohepatitis in these patients. And also NAD+ is required for normal functioning of glutathione. The glutathione is an antioxidant which scavenges the reactive oxygen species inside the hepatocytes. So if this glutathione is reduced due to reduced NAD+, it causes increase in reactive oxygen species. The reactive oxygen species like hydroxide ion and other ions causes lipid peroxidation, and by other methods they causes damage to cell membrane and DNA. The damage to cell membrane is followed by the secondary events like impaired Na plus K plus pump function and other things, which eventually lead on to hepatocytes injury, cell injury. Then these aldehydes, which has been produced from alcohol, can bind with these reactive oxygen species and other proteins to form chemical adducts or protein adducts. Normally, these protein adducts are not present in this body. Since the aldehyde level is increased, some proteins in the hepatocytes bind with them to form protein adducts. These protein adducts causes the activation of immune system and auto-inflammatory attack to hepatocytes. Also, the chemical adducts which are formed are directly toxic to hepatocytes. All these mechanisms increase in reactive oxygen species. Autoimmune attack causes injury to hepatocytes. Now hepatocytes are injured and the immune system is activated. Due to that, the activation of immune cells along with hepatocyte injury. Whenever there is injury and immune activation, it will be followed by fibrosis. In liver, it leads to stellate cells activation and fibrosis. Fibrosis along with ongoing regeneration from normal hepatocytes will cause regenerating nodules, which is seen as cirrhosis. This is how alcohol causes, one of the mechanism how alcohol causes cirrhosis. The other mechanism is the alcohol will cause mucosal injury, causes injury to mucosa of the stomach, We know alcohol is a risk factor for developing peptic ulcer disease. Also in small intestine, it causes impaired mucosal permeability due to mucosal injury, causing influx of endotoxins, which are released by gram-negative bacteria from the gut to the portal system. We all know that the portal system, the blood goes to liver. In the liver, we have Kupffer cells, which are activated by these endotoxins. And due to this activation of Kupffer cells or macrophages, there will be immune attack, which leads on to destruction of hepatocytes, and then fibrosis along with regeneration, forming regenerating nodules, which present as cirrhosis. All these things will, on top of all these things, genetic susceptibility is also required for developing cirrhosis. This is all about the etiopathophysiology of cirrhosis. Now let's see what are the clinical manifestations seen in cirrhosis. Please note, the clinical manifestation seen in cirrhosis is highly variable. Some patients are actually asymptomatic and they are only picked up on doing ultrasound for other causes. Some patients may present clinically with non-specific symptoms like weakness, fatigue, muscle cramps, anorexia, etc., etc. Now, going on to specific symptoms and signs seen in cirrhosis, we have signs due to hepatic insufficiency or damage to the liver, and signs due to portal hypertensions. The signs due to hepatic insufficiency can be broadly divided into signs due to reduced conjugation and excretion of bilirubin, which causes jaundice in these patients. And also reduced synthetic effects, reduced metabolic effects, reduced synthetic function of the liver. We know the liver is responsible for production of vitamin K dependent coagulation factors like factor 1, factor 9, factor 7, and factor 2. Along with, due to the injury to hepatosplenism secondary to portal hypertension, both these causes reduction in coagulation clotting factors and increased activity of spleen, which causes thrombocytopenia, causes bleeding in these patients. The patients may present with bruising, petechiae, epistaxis, bleeding from nose, GI bleed, and menorrhagia. Of albumin, the reduced albumin levels in the blood causes reduced oncotic pressure, which causes edema, peripheral pitting edema. And also it causes ascites due to reduced oncotic pressure. The fluid will go out of the blood, causing ascites. Portal hypertension also contributes to production of ascites due to increased hydrostatic pressure. Both these causes ascites. In 13% of patients with cirrhosis, we see pleural effusion due to reduced albumin levels. Now, these are all the symptoms and signs seen due to reduced synthetic functions of liver. Now, we'll see what are the symptoms and signs due to reduced metabolic function of liver. Due to increased ammonia, we see hepatic encephalopathy and findings like flapping tremor and impaired behavior, gradually leading on to other manifestation which we'll see under hepatic encephalopathy. And also we have endocrine manifestations. Why endocrine manifestations? Because the androstenedione, which is secreted from the adrenal cortex, which is the precursor for estrogen, is broken in liver. It's metabolized in liver. When there is hepatic failure, there will be increased level of androstenedione. Increased level of androstenedione will cause increased peripheral production of estrogen, causing most of the endocrine symptoms seen in cirrhosis. Due to hyperestrogenism, we see hyperestrogenism, that is increased estrogen level. We see loss of libido and layer loss in these patients. In females, we see atypical uterine bleeding, amenorrhea, and atrophy of breast. In males, we see gynecomastia due to increased estrogen level, gynecomastia, testicular atrophy, and impotence. And also, in 80% of patients, we see hyperglycemia due to hepatic insufficiency. Why hyperglycemia? If you ask, normally insulin is broken down in the liver. So when there is hepatic insufficiency, it causes chronic increased level of insulin. Chronic insulin increased level of insulin causes insulin resistance, which leads on to hyperglycemia in these patients. 80% of patients, around 20% of them have associated diabetes mellitus. These are all about the symptoms seen, signs and symptoms seen due to reduced metabolic functions of liver. Also, due to increased estrogen, there will be vasodilation, leading on to spider nevi, where there will be central arteriolar dilatation and surrounding branching vessels. We see palmar erythema in these patients due to increased peripheral circulation, leading on to palmar erythema. Why is peripheral circulation is increased? Because secondary to portal hypertension, there will be release of vasodilators like nitric oxide, which causes increased peripheral circulation, causing palmar erythema in some patients. What are the features of portal hypertension? Portal hypertension we saw is due to distortion and destruction of hepatic vasculature secondary to formation of regenerating nodules. We see hepatic portal hypertension. Secondary to portal hypertension, there will be splenomegaly in these patients. Also, the portal cave and anastomotic vessels will open up, causing hemorrhoids, variceal bleeding, hematemesis in these patients. On top of all these signs and symptoms, the patients can have parotid gland enlargement due to autonomic dysfunction seen in these patients. Due to secondary to autonomic dysfunction, the patient will have impaired secretion of parotid and lacrimal secretion, leading on to enlargement of both parotid and lacrimal glands. Some patients have deputrin contracture due to damage to microvasculature caused due to alcohol, which increases platelet and fibroblast derived growth factors, which causes fibrosis and deputrin contracture. These are all the signs and symptoms that we see in cirrhosis patients. Now, what are the complications that are seen in cirrhosis patients? The complications are portal hypertension, which we saw, hepatocellular carcinoma, spontaneous bacterial peritonitis, which we'll see shortly. Then we have protein energy malnutrition in these patients due to anorexia, chronic inflammation. And also we have involvement of other systems secondary to cirrhosis, causing hepatopulmonary syndrome, hepatorenal syndrome, and cirrhotic cardiomyopathy. In hepatopulmonary syndrome, there will be intrapulmonary vasodilation, leading on to breathlessness on standing, which is called as orthodeoxia platypnea. And also cardiomyopathy, cirrhotic cardiomyopathy, where the patients will have systemic and systolic and diastolic dysfunction. The patients can have hepatorenal syndrome, where the architecture and the histopathological studies of kidney will be normal, but the patient will have progressive oliguria and increased creatine level, bun level, blood urea nitrogen level, and all. This is hepatorenal syndrome. Associated with these symptoms, the patient have endocrine abnormality due to increased estrogen, which we saw. Now, how to manage these patients? What are the investigations done in these patients? The non-radiological investigations like LFT can be done. On doing liver function test, we'll see increased bilirubin level. Serum protein estimation show reversal of albumin and globulin ratio. Increased prothrombin time due to reduced clotting factors, vitamin K dependent clotting factors, and increased hepatic enzymes like AST, ALT, and GGT. The GGT is the most sensitive one, which is the marker for alcohol consumption in the patients. On doing hematological examination, we can see thrombocytopenia due to hypersplenism. We can see anemia because the liver is the second most common source of erythropoietin. We can see anemia, normocytic, normochromic anemia, and acanthocytosis in these patients. We can do serological examination, estimation of antigen and antibody to detect whether the patient have a chronic hepatitis B and hepatitis C infections. Blood ammonia levels will be raised in hepatic encephalopathy patients. We can do ABG, arterial blood gas, in case of the patients having hepatopulmonary syndrome. The arterial blood gas level will be impaired. We'll do liver biopsy if the patient has Wilson's disease and alpha-1 antitrypsin deficiency. The Wilson's disease, the liver biopsy is confirmative of the condition. The radiological examination like USG can be done where the increased echogenicity is seen in initial cases like steatohepatitis. The fibrotic nodules along with impaired vasculature of the liver can be seen on USG ultrasound. Or CT and MRI can be done to look for the hepatic architecture. The fibroscan is a non-invasive method of estimating the amount of fibrosis in the liver. And we can do hepatovenous hepatic venous pressure gradient, where the pressure in the hepatic sinusoids and hepatic vasculature is estimated by passing a balloon catheter into the hepatic veins and inflating it. The normal hepatic venous, the if it is more than 10 mmHg, the patient will be having clinically significant portal hypertension. This is all the investigations that we do in case of cirrhosis patients. Now, how to treat these patients? Unfortunately, we don't have any treatment modality to arrest the progression of cirrhosis. The definitive treatment is transplantation. If the patient has reversible causes, like not reversible causes, sorry, if the patient has any damaging causes like intake of alcohol, drugs which are causing damage to hepatocytes, if the patient stopped drinking or if the patient stopped intake of drugs like methotrexate sulfonamides which are causing hepatic injury, the progression of cirrhosis can be halted in these patients. The diet recommendation in this patient is high protein diet because they will have reduced albumin level in the body. The minimum protein intake should be 1 gram per kg per day. We'll give multivitamin supplements for these patients, and also we advise to reduce salt intake because the patients will have peripheral pitting edema, other things. So salt intake should be restricted. Also, we manage the complications accordingly. If the patient has variceal bleed, we'll give tranexamic acid or we can do electrocautery, etc. The patient has hepatic encephalopathy, we'll treat hepatic encephalopathy. This is all about the alcoholic liver disease and cirrhosis. To summarize, the alcoholic liver disease is a disease caused by chronic excessive intake of alcohol, causing spectrum of diseases like fatty liver, alcoholic hepatitis, alcoholic cirrhosis, and hepatocellular carcinoma. The cirrhosis is the end stage of all chronic liver diseases, characterized by involvement of entire liver, where there will be fibrosis and impairment of normal architecture of the liver, where we can see regenerating nodules inside the liver. Now, idiopathophysiology of these conditions, we have hepatic causes and biliary causes. The hepatic, we have hereditary and acquired. Hereditary, we have glycogen storage disease, cystic fibrosis, Wilson's disease, and hemochromatosis. Acquired causes, we have most common alcohol intake, chronic hepatitis B, hepatitis C infection, hepatitis B and D co-infection, NAFLD, and methotrexate sulfonamides, other drugs causing damage to hepatocytes. Biliary system involving diseases, we have primary biliary cholangitis, secondary biliary cholangitis, and Budd-Chiari syndrome causing cirrhosis. The pathophysiology: first, there will be damage to hepatocytes. Following that, there will be formation of regenerating nodules, which causes destruction and distortion of normal hepatic vasculature, which causes portal hypertension in these patients. The patient will have symptoms of hepatocellular insufficiency. Now, how alcohol causes damage to the liver? Normally, the alcohol is metabolized to aldehyde followed by conversion to acetic acid. This aldehyde will bind with the reactive oxygen species and other proteins, causing forming chemical and protein adducts, which causes autoimmune attack to the liver and also has direct toxigenic effects on hepatocytes. The metabolism, the conversion of alcohol to aldehyde and to acetic acid, causes it consumes NAD plus. It converts NAD plus to NADH. The NAD plus is required for fatty oxidation and normal functioning of glutathione antioxidant system. The reduced level of NAD plus causes reduced fatty oxidation and steatohepatitis. The reduced glutathione function increasing the reactive oxygen species, causing oxidative stress to the hepatocytes. All these causes damage to hepatocytes. Along with that, the mucosal injury caused by hepatocytes causes impaired permeability of the GIT, where there will be influx of endotoxins into the portal system. The endotoxins reaches the liver, and then there the Kupffer cells will get activated and cause inflammatory damage inside the liver. All these factors causes destruction of hepatocytes followed by fibrosis due to activation of stellate cells. And then there will be associated regeneration, forming regenerating nodules and cirrhosis in this patient. So the clinical manifestations, we have non-specific manifestations like weakness, fatigue, and muscle cramps, anorexia. The specific clinical manifestations are due to hepatic insufficiency, due to reduced conjugation, excretion of bilirubin, we have jaundice. Due to reduced synthetic effects, we have bleeding manifestations, and reduced albumin, we have ascites, pitting, peripheral edema, and pleural effusion in 13% of patients. Due to reduced metabolic functions, we have increased ammonia, hepatic encephalopathy, patric, flapping tremor, and endocrine effects we have due to increased estrogen level. There will be loss of libido, hair loss, and in females, AUB, amenorrhea, atrophy of breast; in males, gynecomastia, testicular atrophy, and impotence. And there will be hyperglycemia in 80% of patients. Due to portal hypertension, the patients will have splenomegaly, hemorrhoids, variceal bleeding. Associated with this, the patient have spider nevi, palmar erythema, parotid gland, and lacrimal gland enlargement, and uterine contractures. The complications are portal hypertension, hepatocellular carcinoma, spontaneous bacterial peritonitis, protein allergy, malnutrition, hepatopulmonary syndrome, hepatorenal syndrome, and cirrhotic cardiomyopathy. And also we have endocrine abnormality, which we discussed. The investigations we do non-radiological and radiological. Non-radiological, LFT will be grossly impaired. Dermatological, we have thrombocytopenia, anemia, and acanthocytosis. Increased blood ammonia levels if the patient has hepatic encephalopathy. ABG will be indicated in cardiopulmonary syndrome. Sorry, hepatopulmonary syndrome. And we do biopsy in case of if we suspect Wilson's disease, alpha-1 antitrypsin deficiency, and all. Radiological examination, we can do USG, CT, MRI, and hepatic venous pressure gradient. If it is more than 10 mmHg, the patient will have clinically significant portal hypertension. Treatment, we don't have any drugs to arrest the progression of cirrhosis. The liver transplantation is the definitive treatment. The progression can be halted by stopping the substances which are causing hepatic injury. Those are alcohol and drugs. The diet, we suggest high protein diet, minimum 1 gram per kg per day. We give multivitamin supplementation and reduce the salt intake. We suggest the patient to reduce the salt intake, and we manage the complications accordingly. That is variceal bleed and hepatic encephalopathy. Variceal bleed can control by tranexamic acid and other methods. So by this, we are ending discussion on alcoholic liver disease and cirrhosis, most important 10 markers. Thank you for listening.